Okay, good morning, everybody. Looks like we're ready to roll. Dr. Manakas coming in hot this morning on his 5-year anniversary today. So,
It was the celebration. Is that today?
celebration is today at 5 o'clock, 5-year anniversary. This just have the distinct pleasure of introducing Dr. Manakas, our speaker this morning. He graduated from medical school at the University of Indiana in 2006 and 5, and finished his I'm doing this by memory. Completed his residency here at University of Wisconsin in 2010, and then joined our faculty in 2018. He's our leader in the department for informatics, and has done some really great work in that area, including developing some really great smart sets that have made our lives a lot easier in clinic. I'm going to try that bladder cancer one out today. So thank you for all your work there. And he's going to give us a wonderful talk this morning. He's done a lot of work in the area of holmium laser nucleation of the prostate, including the learning curve. And I've been told it's a pretty steep learning curve. Dr. Grownick told me that's why I couldn't learn. So, but we're really glad that you're part of our team, Chris, and look forward to your talk this morning.
Thank you, Kyle. Really appreciate the introduction. I got probably more slides than time for, but we're gonna get right to it. Thanks for the opportunity to present. Is microphone okay? Everybody hear me okay? Excellent. And slides are displaying to folks online. Excellent. So today it's going to be a little variation on a theme. I was asked to give a talk about learning HoLEP again, and this is a little modified version, kind of talking a little bit more about the why, when, and of course the how to. Disclosures real quick, consultants for Boston Scientific, Richard Wolf, and objective today, what we're going to talk about, we're going to describe that HoLEP as an effective, durable, versatile procedure. We'll identify those patients that might benefit from HoLEP, talk about the learning curve, and then how we've gone from a procedure to a program. So what is HoLEP? I often answer this question in the operating room with medical students. I ask the question, can you compare a radical prostatectomy to a simple prostatectomy, and the indications therein, and how they may be different? This is an endoscopic simple prostatectomy that was first described in 1998 by Gilling and Fraundorfer. Took many years of technological refinement and equipment improvements to have a significant increase outside of New Zealand, where Dr. Gilling resides. And it really, though, presented a compelling improvement in a excellent technique for relieving obstruction. The simple prostatectomy, though, was morbid. It required open procedure, required a low midline incision, opening the bladder, a significant amount of blood loss, often in patients that were not going to tolerate that kind of procedure very well. They would be in the hospital for 2 to 3 days, suprapubic tube, urethral catheter for days, weeks, and it took a long time to get back to their regular activity. There's side effects associated with that procedure, morbidity with that kind of invasive procedure. And it replaced it with something that's natural orifice. HoLEP has a very low transfusion rate, less than 1%. You have an outpatient surgery now, most of the time, and very little discomfort, Foley catheter for less than 24 hours. So it's really a stark contrast, and I often describe it as a difference between an open cholecystectomy and a laparoscopic chole. I mean, it's a big deal. It solves a problem. We'll talk about that in just a bit. And of course, it's just one of many BPH treatments, and Dr. Grolnick gave an excellent talk last week about how this fits in the paradigm of options. But, why HoLEP is something we're going to talk about in some detail here. HoLEP outcomes are well established in the literature. Here's some examples of the efficacy, 1,000 HoLEPs from Dr. Lingeman's group, and another large cohort of patients. I believe this was over 500 HoLEPs in Canada, and 10-year data fantastic, durable improvement in their IPSS scores from pre-op of 20 here on the Crambeck paper, and looks like they settled down at 5.1 10 years out of those patients who were available for follow-up. You can see the flow rate improvement was incredible and durable. And that's been validated in studies all over the world that it makes sense. You know, you're taking away that transition zone from the peripheral zone in a way that theoretically you shouldn't have much regrowth because you're getting it all out in a way that can't grow back. And conceptually, that's what I think leads to its durability, right? You have very low retreatment rates, well established in the literature. Comparison studies have been done, you know, TURP versus HoLEP, 17% to 0% for retreatment rate over 7 years. TUIP retreatment rate comparable, 14.8% in 8 years. You have a randomized trial that showed PVP versus TURP versus HoLEP. HoLEP, 0% retreatment, PVP and bipolar much higher. And then you have some of the newer MIST procedures. And I don't think anybody is thinking these are going to last forever, but this was a McVary paper, looking at the early data, long-term data on 2,000 UroLift patients. And at 5 years, they quote a reoperation rate of 29%. That doesn't include the patients that never stopped their medicine or the patients that resumed medicine in the interim before they had to have reoperation. So HoLEP is durable, it's effective compared to other procedures. The recovery is predictable, and although the incontinence associated with the recovery is often criticized as a downside of the treatment, with appropriate counseling, patients can be prepared for what is expected leakage in the first 2 to 3 months. That transient incontinence, depending on the paper you look at, is somewhere between 20% and 90%. I think it depends on the patient's if they're leaking before, but we know that regardless, they come in, they have a HoLEP, there's about a 2.2% chance of stress incontinence at 12 months, a 1% risk of urge incontinence at 12 months. And although the paper said 75% retrograde ejaculation, I just tell patients to expect it rather. That if they'll have a preserved orgasm, but they'll have diminished fluid and likely no fluid at all with a climax. The versatility is what has, I think, opened up a large population of patients for HoLEP. You see in the guidelines here, you endorse for small glands, medium glands, large, extra large. It is the only endoscopic procedure, and the only procedure really that is endorsed as appropriate for any size prostate. The versatility with regard to anticoagulation and antiplatelet therapy is a major focus for us as we deal with patients that our recent examination of our own data showed 50% of our patients are on some form of antiplatelet or anticoagulation. And these, quote, medically complicated patients in the guidelines are a significant percentage of our patients that would be very difficult to manage with other BPH procedures. And HoLEP, PVP, and ThulEP are endorsed in the guidelines for appropriate in these patients on blood thinners. So we have this procedure that can be done as an outpatient. They can stop medication immediately and have no plans to restart it. I tell patients to expect 10 years of in 10 years of follow-up, 99% of patients don't need to resume medication, don't need to undergo another surgery. The counseling is, of course, key as you're weighing the pros and cons of intervening. And I emphasize over and over with patients, you know, I spend very little time actually talking about how we do the procedure. You know, all of the unfortunate brief encounters we have to talk about the surgery, it's 90% of it is the recovery. This is what you're going to expect with that. This is how you can expect how much leakage you can expect to have. You know, bring a diaper to your void trial so that you can not have an accident on the way home. You can expect that incontinence to last for days, weeks, and months. They go to physical therapy as a routine for preoperative pelvic rehab so that they have yet another validation that this leakage is expected part of the procedure recovery. And though not everybody has significant leakage, I would way rather over-prepare everyone than have folks say that, no one said they were going to have some incontinence. If you talk to the staff, clinic nurses, our physician assistants, anybody that might be involved in these patients, they really don't think, there's a large number of them that really don't think it's going to happen to them. And so I think the more times that we reinforce that, it's important. But these are the folks that you have to keep reinforcing those expectations. But have a catheter for a day or two. There's groups out there that are practicing and publishing on their data for same-day catheter removal. What I'll say about that, we've experimented with it, and when I talk to patients, if they've never had a catheter, the thing they are most afraid of with this procedure is having a catheter. And if you go down the road of, well, maybe you'll be able to have that catheter removed before you go home. And what if they fail that void trial on the same day and then have to have it replaced while they're awake? It's just this, it's just to me, and Dan and I agree on this, is an unnecessary risk. And you want to just try to get them through this smoothly, safely, and having a catheter that they keep for a day or two is minimal morbidity. So with all of this accumulated data, HoLEP is often looked at as a new gold standard for BPH. And so that brings us to, when should we HoLEP, right? What is that patient that is a HoLEP candidate? And this is going to be a lot of information that I want to just have available for you. And of course, happy to share my slides with you. But quickly, the due diligence up front is so important. And as is the case with any surgery, and as much as we want to talk about and focus on technique and what's the best way to do that early apex release, and can we spare ejaculation by leaving the lateral lobes, which could be a valid approach to enucleation and improve outcomes, but you can be so much focused on the technique, but as we all know, patient selection is paramount. And if you want to have a good outcome, you have to have appropriate expectation settings, and you have to have the appropriate problem that you're trying to solve. And these next several slides are just about that. And so establishing the problem, defining the problem. What's their IPSS score? You've got to have that before you do this so that you can not only have high quality data that you can look back on. How it is the standard of care practice in urology. You got to have an IPSS before and then after. You have to have your urinalysis. You got to make sure that bladder scan has been obtained beforehand. Consider getting a PSA if they have life expectancy over 10 years. Indefinitely get that voiding diary in these patients with predominant storage symptoms to see if they have any evidence of nocturnal polyuria, because there's been countless patients that have come in looking to solve their nocturia with HoLEP, and they get a voiding diary, and they go 3 times during the day. They take their diuretic at night, or they're drinking half of their 2 quarts of water a day just before going to bed. And it's like, hold on, HoLEP can't help you. Get that uroflow if you can, to help with decision making, and of course, flow rates, equivocal versus normal, slow. When the patient has failed medical therapy, a couple of points here I want to make out of the guidelines. And don't spin the wheels with trying every single alpha blocker available if they haven't responded. It's one thing if they've had an adverse reaction or side effect to a medication in that class. You might try a different alpha blocker in the class and see if they'll get a therapeutic benefit. But if they're not getting any benefit from alfuzosin, tamsulosin, silodosin, they're not going to get a benefit from a different alpha blocker. That's established. And there really isn't any efficacy superiority within the alpha blocker class. 5 ARIs, of course, add that if the glands are more than 30, which seems to be every prostate AC, with appropriate counseling about the side effects. And I would say that one of the biggest side effects is prescription drug forever, and it should be part of your counseling. Dan alluded to it last week when he talked about BPH treatments. But this is, this isn't like you try this tamsulosin, you get a relief from it, and then you also eat the right foods, do the right exercise, then you'll be able to wean yourself off the tamsulosin. It's not like an antihypertensive, or maybe you get started on metformin and you work on your diet, exercise, and you're able to be like out of that pre-diabetic class. This is, you're on this medicine, you're going to get the relief from it, and it's going to be medication for life. And that alpha blocker, ejaculatory dysfunction is real for patients. And when they complain about it, it's too often referred to as retrograde ejaculation. And this was a little nugget I got out of the guidelines, rereading them before this. And I don't know if I caught this before, but it's an ejaculation. They looked at a semen volume compared to post-ejaculation urinalysis, and patients getting tamsulosin, there was no semen, there was no sperm in the urine. It was truly an ejaculation, a paralysis of the smooth muscle that leads to a loss of sensation. And that's a lot to ask of a guy, any guy, to give up completely that sensation so that they can treat their LUTs, because it's, it says so here, we should do this. And so make sure they're aware of that. 5 ARIs, significant sexual side effects, 20% erectile dysfunction, 10% decreased libido. This was interesting in how much the recent guidelines have pushed back hard on this concept of post-finasteride syndrome. They believe it's not anything that you should consider as real. It should be looked at as spurious data, and that all the randomized trials on those looking at men who took finasteride had no residual effects documented about sexual function. Just wanted to get that out there. This last point is, I don't know if anybody actually thinks of it as controversial. I think it's been established for decades that we know that if, because there was a great study, a VA study looking at men who had TERP versus the combination medical therapy, and then 4 years later they had a TERP. And the patients who had the TERP early had better outcomes than those who had a TERP 4 years later. And we don't know exactly why, but there's a lot of evidence to support delaying intervention on significant obstruction can lead to long-term detrusor dysfunction, urgent continence. That is something that will persist even if you unobstruct their outlet. And it's a fantastic research opportunity, but it should be part of the patient counseling that if they are bothered, if they have significant storage symptoms, evaluate that patient, study them with a pressure flow study, and get more data as you try to help them reach their goals. And if they're fine with that, they're fine with medical therapy, great. But if they really want to get better, I think you're going to be better off with more information in these circumstances to help counsel about outlet procedure. Retention. HoLEP can get people out of retention better than anything else short of a radical prostatectomy. Of course, we're not going to do that for benign disease. Sometimes we do it for Gleason 6 cancer, but that's beside the point. The atonic detrusor on urodynamics, we just didn't have this in our toolbox before. What did we do? We studied guys who came in, they had 4 liters in their bladder. Well, we're going to have to do urodynamics on you because we don't know if we're going to be able to get you catheter-free. You're going to have to learn how to catheterize yourself forever, and that's probably the most likely scenario for you. Well, your prostate's small, you have minimal detrusor function. This is the way it's going to be. That's a patient we do a HoLEP on today, and the vast majority of the time they urinate. Maybe it's with the Valsalva, but these guys will absolutely trade catheter for Valsalva, and this has been validated in literature and in multiple studies. So we don't know exactly why, but we know that HoLEP does a very complete removal. And this is true, too, in patients who've had retention in previous failed BPH outlet procedures. Say they've had a TERP, they were in retention, they had a PVP, they were in retention, they're still in retention. I have dozens of patients in exactly that circumstance we've done a HoLEP on, and every single one of them is catheter-free. Quick comment on storage versus emptying symptoms. I talk about this a lot in the operating room when I'm talking to medical students and residents, and sometimes just talking to myself. But you have emptying symptoms versus your storage symptoms. Emptying, it's a little bit more intuitive. You're talking to patients, you got a weak stream, you got chronic retention, you have hesitancy, interrupted flow, you feel like you're straining to urinate. We go and we unclog that drain, you're going to have a predictable outcome. Storage is a little tricky. And you have the IPSS form that's got 4 emptying and 3 storage questions. And if somebody's just like 5's down the road, 35, everything's horrible, quality of life is 5, you could probably help them with HoLEP. I think studying them is going to be, in those circumstances, you're not going to lose by having more information. But what I want to talk about here is along the lines of that VA study is we don't really know at all when surgical intervention when's the best timing for surgical intervention in these patients. It's a fantastic opportunity for investigation. And as we look at these missed procedures, which one actually does a good job of unobstructing and how much unobstruction is enough to prevent long-term sequelae of obstruction. It's muddy waters when you look at the overlap of aging impact and comorbidity impact on detrusor function and the detrusor bladder complex. But you have to keep this all in mind as you're talking to people and really focus in on what they want to solve. And that's the first thing I ask somebody when I meet them is, I know what HoLEP can accomplish. I know it's better than anything I've ever been able to do for patients to relieve the obstruction. But what do you want to get out of this? Because if you're hoping that your urge incontinence, fecal incontinence, and difficulty standing up and getting to the bathroom in time because of your spinal stenosis is going to get better with a HoLEP, I can't help you. Okay. There might be opportunities to investigate further with urodynamics to see just how obstructed you are, and then with appropriate counseling, you can talk that patient through an outlet procedure. But we should be careful in these circumstances, be aware, though, about delaying intervention and the consequences, and really critically think about what these other interventions are hoping to accomplish. Okay, quick, gross hematuria. We see it all the time. And that's actually one of the ways that I found a bunch of early cases for HoLEP was these guys on medical therapy. They come in, they got gross hematuria, they're on warfarin, Plavix, and Eliquis. You got a CT urogram, you're going to measure that prostate. Holy cow, it's 150 grams. We used to put those patients on finasteride. And it took a moment to just look and see why. And it comes out of a pretty small study, but objectively good data, saying that the finasteride group of this patient had much less hematuria in a prospective study, long after finasteride was out and available. But that's medication for life. And of course, finasteride is not magic. Prostate's still going to grow. And they're at risk of not just bleeding recurrence still on finasteride, but progression of their LUTs if they're bothered by LUTs. And HoLEP's a fantastic definitive treatment for this hematuria because of how completely it removes that transition zone and the source of the bleeding. And so those patients on blood thinners, where you might have thought of finasteride 20 years ago, don't forget about HoLEP. And this is from Campbell's, medical therapy first line for patients bothered by LUTs, but for those with retention, recurrent UTIs, insufficiency bladder stones, and hematuria, that's your imperative indication for surgery. All right. Along those lines of hematuria, I couldn't resist this slide and showing off what you really have to see to believe. And I certainly had to, and really prompted by a patient who had a low flow, he had a mechanical mitral valve, was faced with either INR, or excuse me, continuing to warfarin or bridging him. And then your, INR is going to invariably not go straight back to where it was. You're going to maybe overshoot, undershoot. You're going to be back and forth. Their diet's going to be changing perioperatively. And this is not a abstract concept. This happened all the time in patients who we'd have on warfarin, you'd have the BPH surgery, their INR would be all over the place afterwards. We just keep them on it. And this is what it looks like. And that's objectively amazing, because there's not a single person in the room that hasn't sat there in the emergency room irrigating these patients with a 6i and getting a liter of clot out of their bladder while they're being transfused and they've got hypovolemic shock from gross hematuria in these circumstances. This is an incredibly powerful tool to solve a very difficult problem, and simply had so few options before HoLEP. But who's not a HoLEP candidate? Really want to assess that frailty, and however you feel that's most appropriate. I really want to bring folks in who are elderly, or you're looking at the chart and they're considering HoLEP, and then, maybe they could do a virtual visit from 300 miles away. It's like, I really want to see that 90-year-old before we sign them up. So can't absolutely have that frailty assessment. And of course, they have to be willing to accept the risk of the side effects. I talked about the nocturia piece and making sure that you're not hoping to solve nocturnal polyuria with HoLEP. Obesity is, there's some wiggle room here with the BMI of 40. That prostatic urethral length plus high BMI puts you at risk of coming up against the length of the scope. And HoLEP really does push the limits of endoscopic surgery. This kind of guidance about BMI more than 40. I know I've done plenty of patients with BMI higher than 40, but be careful, because you might not be able to get in. And that should not be in your first 5 cases where you cannot get the scope into the patient. You're just starting to laser and hoping you can finish it. Ask Dr. Grolnick about the Coney Island sign and what that means. I for real got a referral once for a patient for HoLEP with the prior prostatectomy. Don't do I strongly discourage anyone taking diabetics uncontrolled. And of course, if they can't get into lithotomy position, you can't do a HoLEP. All right, so does anybody know who this is? Quick break. Sarah raised her hand. Dr. McCachran, who is this? Bubs, it's Bubbles. We are in a bubble of HoLEP volume, and maybe there's a handful of other places in the country where the BPH surgical procedure of choice is HoLEP, and you have 5 and soon to be 6 staff urologists doing HoLEP. You truly are in a HoLEP bubble. This is Reginald Bubbles' Cousins from HBO's The Wire. If you haven't watched that, I'll wait. You can go watch the 3 seasons and then come back. Is it 3 or 4? 4? 5? 5. Yeah, 5 on, anyway. So we live in a bubble of HoLEP, and this is meant to demonstrate, well, why isn't it performed more often? It may come as a great surprise to some in the room that it still remains only about 5% of BPH procedures are HoLEP. I mean, I think it's close to 95% here. So it's a little bit upside down here. And this graph is a little old, but the shrinking line of green light is only going to continue to shrink, because the data that was shown at the AUA earlier this year showed that UroLift is rising rapidly in popularity and procedure volume, very much replacing green light, and TURP and HoLEP are kind of static. So why? Well, part of it is because HoLEP is hard to learn, and it really is the one thing that most people know about HoLEP, is that it's hard to learn. And yeah, I would echo that. It was the hardest procedure I ever had to learn. And we'll talk a little bit about that whole process for me. But this learning curve is there is no single learning curve. This is a kind of one example of like the journey any of us might take as we're trying to learn a new thing, but especially a surgery that's complicated with equipment that we're not familiar with, and a anatomy that we aren't familiar with and can't directly see in front of us. You look at other procedures that are widely accepted standard of care. Radical prostatectomy, I mean, those conversations about learning curve 20 some years ago now quickly went by the wayside because Da Vinci deployed a bunch, or Intuitive deployed a bunch of Da Vincis, and it was this equipment arms race to everybody get a robot. And yes, there was a lot of academic discussion about learning curve, but it's still like 40 cases. And this is just one example. And a lot of studies were longer. Robotic cystectomy, 16 to 30. And that's for experienced open surgeons. And it does not include the intracorporeal anastomosis piece. PCNL, 12 to 60. I think it's dependent on so many different factors. Where is the learning curve occurring? Is it in your residency and fellowship or out in practice, which is very different when you're trying to take on a new procedure. But yeah, HoLEP looks like it's about 30 to 50 cases. And so you have strategies around having less of an impact on your practice with that learning curve. Starts with getting past those barriers, and you get the equipment. You get yourself that high-powered laser. You get that morcellator, which is not being used by anybody else in the operating room. It's a single procedure piece of equipment. There's expensive new scopes that may need to be purchased. I talked briefly, though, there really is a limited access to training, though it's improving as HoLEP's popularity increases and patients start asking for it. Programs are looking for someone to do HoLEP, which really is where you're going to have the fastest uptake, is when you indoctrinate the students and the residents, and you train them how to do it properly. Learning it out, though, in practice is really hard. And a lot of it does come down to economics because it's time consuming. And if you can do 10 Euro lifts in the time it would take you to do one HoLEP, well, obviously you're not gonna do a whole Euro lift on a 200-gram prostate who's on warfarin that can't be stopped. But it's an opportunity cost for surgeons out in the field. And that's the case for a lot of these things. And so it's not so much comparing to radical prostatectomy or partial nephrectomy or PCNL. It's, well, how's it compare to learning green light or UroLift or iTind? Yeah, it's a lot different. So what's a good HoLEP outcome when you're in your learning curve here? It's like, did you finish it? That's great. And did you finish it without it breaking you? Because it can be emotionally taxing. The heart rate goes up. You're sitting there on hour 3 as you're like lost as can be and hoping that you can finish it without anybody necessarily over your shoulder waving the plastic stick. That's hard. So you got to have a plan. And that's where this kind of backup plan of conversion to TURP, PVP for some of the smaller glands, that's a great way to set yourself up and keep the patient safe. You know, you don't want to be on there hour 7 or 8 for your nucleation and just for the sake of you saying you did a HoLEP. You know, the longer nucleation time has been shown to have, you know, regardless of how big the prostate is, the longer you're taking to enucleate, the worse your post-op incontinence and longer that it takes for you to recover that incontinence. And probably because you're lost and digging into places and delivering energy into places that you shouldn't be. So one of the things I say over and over is just be safe, but don't be slow. Right? As with any surgery you're learning, got to know your anatomy. And you know, when I first started HoLEP, I wasn't pre-HoLEP. I was doing TURPs, and I barely imaged anybody unless you did a scope, a cysto on somebody who's got refractory Lutz. You see a big one, whatever that means. You roll them over and you do a truss, and holy cow, it barely fits on the screen. It's like, well, I'm gonna probably put that guy with an finasteride, and maybe we can get him down to something. But the paradigm is completely changed now, and nice to have it in the guidelines that, yeah, you should look at imaging and see exactly size and shape, because the morphology varies incredibly. You have wild asymmetry, especially in these 100, 150 plus prostates, huge median lobes, massive anterior tissue. And if you were to just do a green light on somebody with, you know, 80% of their prostate anterior, you rarely ever touch the anterior lobe of the prostate when you're doing any of the BPH procedures. And aquablation specifically completely ignores like 10 to 2 o'clock because of the way it does its little windshield wipers. All of that's left over. So here's some back-to-back HoLEPs on a day just to demonstrate the one example of what imaging can tell us. And as you're building your practice, imaging frequently before you do these so that you have a sense of the size and shape. And then your equipment is so important. And so many, Dan and I have had the privilege of working with some surgeons that are in their own learning curve, out in the field. You know, they've gone through residency, fellowship, whatever. They've been in practice 10, 20, 30 years. And the common theme is, yeah, my hospital won't give me these scopes, and so I got to rent stuff. Or we've cobbled together this, that, and the other thing. And so that's another bubble that we live in, and that, you know, Meritor, we've got 4 full pans of these beautiful store scopes, 2 more coming. You guys have, I don't know how many, 3, 4 pans in the Wolf stuff. So we're flush with equipment. And when you go out and you get your jobs, you make sure that you ask for that right away. And that's something we're happy to help you with. But you got to know what you need, and it's not going to be at the hospital where you go to work. You can't assume that anyways without taking the list that we can give you, and make sure that you've got all the whether it's stores or Wolf, but you've got the 26, 28 French sheath, the laser bridge, the offset scope, the morcellator, and everything else that goes with it. This little plastic catheter is to help stabilize the laser within the laser sheath. Don't skip any of these steps. Get all the right gear. You don't want this to handicap your progress through the learning curve. I talk about this all the time with new trainees to come in. I love now that we get interns at Meritor. I can indoctrinate them into the playing with the scopes and the back table. Just put some sterile gloves on, take it apart, put it together. The sooner you figure that out, and when the lights are on, the more likely you are to be able to troubleshoot when the lights are down and you're leaking fluid. The morcellator, I had to keep this in there. It's good. It's not great. It is a finicky piece of equipment that you must become the subject matter expert on, because if you don't, the staff aren't going to know how to help you when you're stuck. They simply don't use it any other day of the week, and maybe they haven't been in your room in 3 months, and they're not going to know which button to push. You got to figure it out. You have to understand how the device works and where all the different pieces can fail. We had just Monday. Ali was there for that one. The O-ring, we thought we saw it in there in the handpiece. We're not getting any good suction, and it was there. It wound up falling out of view, and we just had to get another handpiece. You know, you continue to learn new ways that this piece of equipment can disappoint, but it's still the best version of it out there, and you just have to own the different ways that it can fail and know and have a backup plan if it does completely. So how did I learn? We're coming around the corner here. How much time do I got? 7:38. Can't say enough, and I can't express enough sincere gratitude to Dr. Gralnick for saying, sure, let's go do those. And I think it's a quote. Yeah, sure, come on down, it'll be fun. That was in 2018, and here we are 5 years later, and more than 2,000 HoLEPs in the program. And I think a lot of it was, for me, driven by this whiteboard of from early on, just tracking on times to have that instant feedback of how long did it take me to do this? How much did we get out? And from there, well, you know, you're watching yourself get better. And I think that measurement really does drive improvement. And in 5, 6 years now, we have gone from a procedure that Dr. Gralnick decided to take on and teach himself. And we go from this to a real program that we're all very proud of. And these 5, and I don't know why I've got asterisk next to Emmy, but she's not quite. She's fellow, she's coming on, and she can do a HoLEP. 6 staff and 2 hospitals, and however, 5 lasers, more stimulators. Big, I have to have a shout out to RPA, Sarah Hermson. She works, of course, with, and there's a number of APPs that work with HoLEP patients. But I know Sarah's done the majority, the lion's share, and maybe more pre and post-op visits than anybody else in the country. Seriously, and she's been instrumental in helping us improve pre and post-op care. So thank you to Sarah. But the residency training piece of our program is something we're all very proud of. And if learning the procedure was hard, learning to teach it was so much more difficult. 10 out of our 12 presidents in the last 4 years are 11. Shapiro said he can do it. Wang is doing it. So one of the things we're focusing on is how to teach HoLEP better. This I stole from the program, but this is great. That's the HoLEP wand, and of course the weapon of choice there, Van Buren sound. We did a study, Dan and I did, with the help of Dee and Anna, and of course the residents as our subjects. But this was from 21 to 22, academic year, looking at how and organizing our teaching program into these steps that we had a form to fill out about whether or not competence had been reached within each step. And we proved that in residents who had, every single resident, a PGY4 and PGY5 who went through the program were able to complete a HoLEP successfully, less than 100 grams. And the goal, the primary endpoint was, could you finish that 100-gram HoLEP in less than 90 minutes? And everybody, so PGY4s and 5s did, and the average time to finish was 47 minutes, and gland size 83. And in those parentheses next to the PGY, that's how many cases they got to do in their training program in that year. So I went backwards. No, one thing I want to make sure I touch on is what is an instrumental addition to the program in the last year is our BPH clinical research work group. We have a group of physicians, APPs, research assistants, and then any interested residents. And we do get a little bit of time with our endo fellow. We have an IRB for quality improvement, and from there we've had several abstracts, even a paper that is, I believe, accepted for publication now. And in one short year, we've had a lot of I'm really compelling, and I would say it's fun for me to work with such a dynamic group of people. And so many super thanks to Matt Grimes. I don't know if he's, I don't want to look too far around, but if he's online, wonderful. If not, I'll say thanks to Matt in person. But he's really been who spearheaded and has been a tremendous organizer of this group. And we've done so much to standardize clinic operations, documentation, patient education, so that we can help enable better data collection and then have a feedback loop from the data that we're examining and the clinical practice. It's really a lot of fun. A couple of things that have been in the pipeline recently, and we'll wrap up, but we've got always opportunity for improving outcomes. And these are a couple of examples. Can detrusor Botox at the same time as your HoLEP improve your incontinence? Doesn't seem like it does too much, but and this was a retrospective study that it definitely worth some further scrutiny. One example of the novel technique of can we preserve ejaculation with HoLEP? I don't think that's a HoLEP if you don't take the whole transition zone, but this particular paper did show that of the 40 patients sexually active, 35 had preserved ejaculation by only taking the median lobe. Okay. So as far as what can we do in the future to learn more about HoLEP and ourselves and how we manage HoLEP patients, we're going to work on refining that UW HoLEP curriculum. There's always opportunities for streamlining our clinical data collection. This is, I think, very important as we look to improve overall quality of care for patients in BPH, lots from its primary care education. along the lines of medical therapy when it's appropriate, when it's time to just move on and get patients to us so that they can have a better outcome and we can at least evaluate them and counsel them about what options might help them reach their goals. Patient education, you know, I love a well-informed patient, but they don't get it from Dr. Google. They really don't. We have to do better at helping them understand their condition so that we can get them what they need. And then IPSS, is this it? You know, is that it certainly is the gold standard. It's what we hold ourselves to as we assess our outcomes for BPH treatment. And there's been many, many other instruments brought up alongside it. But does it, you know, I think an important question is, does IPSS really matter to patients especially as we explore some of these missed procedures? All right. One thing I want to put up at the end, these are my favorite pictures to get. These are all times. Give me a second. Yeah, you guys, when you leave, you take this with you. And that's really cool. So anyways, that's it for today. I really appreciate all the time you gave us and you give me and you give all of us as you look to try to learn this. But that's it. Thanks for your time. Happy to take any questions.
Great. Any questions for Dr. Manakas? Dave Gerard.
I'll kick it off. Yeah, thanks, Chris and Dan. Thanks last week for your talk too. Yeah, I have a lot of questions actually. So one question really gets to this issue of incontinence, and I think about surgery for prostatectomies, radical prostatectomies, and obviously there is this. These patients have many of them have significant issues initially that approves, just tracking some of our data, 3 months, they make a rapid improvement. Yeah, it's interesting that you do see this kind of similar trend with HoLEP. I guess the question is, have you looked at preoperative predictors, for example, irritative voiding symptoms? One thought is, sphincteric length. I know in prostatectomy, there's been some debate about that, and so your thoughts on that?
Well, that's a lot, but no doubt there's some parallels to the impact on continence. But in general, a HoLEP patient is older, and we know that just age is going to negatively affect their bladder function and particular storage symptoms. So there's opportunities for investigating better the preoperative parameters that may help with risk assessment and then therefore risk mitigation with intervening. It's the question. It is the question is what patient is best and when to have an outlet procedure. We've identified, and it's not just us, the patients who have incontinence, particular urge incontinence beforehand, will take longer to recover. Though that patient becomes you can more practically intervene on their urgency if they have persistent urge incontinence with something like Botox or a beta-3 agonist or antimuscarinic and have a desirable outcome. But if they're retaining and elderly, if they're retaining 400, you're not going to put that guy on an antimuscarinic. And you're also not going to take an 80-year-old and put him on an antimuscarinic and take a risk of the cognitive difficulties. So you have to solve the obstruction, move towards the urgency with appropriate study. That's a blanket statement, but it's always patient specific. Your comment about the sphincter length has been looked at. And I think it was an abstract at the AUA that went to try and examine sphincter length in MRI patients, HoLEP patients who had MRI examining incontinence rates, and there did not seem to be a correlation. But that's what I can tell you about what I've seen on sphincter length.
Yeah, there's, certainly with prostatectomy for cancer, it's a little bit of a soft correlation. So, yeah, it just what I'm hearing from you is maybe there is not really a clear correlation with anything that you've come across. It just seems like a ripe area for study if you could help you in counseling your patients as far as
Absolutely.
stratify that.
I mean, there's a bunch of different instruments used for incontinence assessment, and finding the right one. Yeah, we're right now using ICIQQI short form. It's 4 questions, and what we're certainly we've been using it now for about 9 months, and preoperatively, it helps me identify a lot more patients that are actually leaking, and I know that. So when I identify those, I definitely prepare them for potentially a longer recovery. Absolutely. I mean, all the comorbidities that go with so many of our aging population, but you're diabetic, you're patient with vascular disease, whether there's any neurogenic component, the bladder is going to be affected by that.
So we have Journal Club coming up, but this is not a question, it's a comment. So I've certainly seen, so transition is difficult, and I've seen, academic urologists go into private practice, and I've seen private practice urologists go into academic practice or educational practice. And there's no doubt in my mind the latter is harder. And, both you and Dana Gralnick have done a great job with this. So congratulations. And that's it.
Thanks.
All right, we'll transition to Journal Club. Do we need a minute? Take a break, or should we keep rolling? All right. Let's take 2 minutes. Load up. Do we have slides or no slides?
Let's load up the Pinnacle study first.